Hi, everybody, and welcome to part 7 of our 10-part GI lecture series, designed for those of you studying for USMLE Step 1 or COMLEX Level 1. Today, we're going to talk about the rectum and the anal canal. We're going to take the same framework that we've been taking in each of the previous lectures, so we'll start with anatomy. And I want to begin by talking about some of the different regions of the rectum as well as the anal canal. And then we'll spend some time talking about the pectinate line, which is probably the most important and heavily tested concept in the entire rectum section, whether it's anatomy, physiology, or conditions. So there's 5 regions I want you to know about. The first we've talked about before in the large intestine lecture. This is the rectosigmoid junction, and I've highlighted it to the picture to the right. The reason why the rectosigmoid junction is important is because it's a watershed region. And so watershed regions, as a reminder, are regions at the very end of your blood supply. And because they're at the very end and they have the least amount of perfusion, they are they're the regions that are most at risk in the setting of systemic hypotension, like shock. In the large intestine, you need to know 2 different watershed regions. There is the splenic flexure, also known as Griffith's point, and there's also the rectosigmoid junction, which we're talking about now. And I have in the picture here, you can see how when the blood supply comes directly off of the superior mesenteric artery or the inferior mesenteric artery, there's very, very high perfusion pressures. But as the blood supply starts to go more distal, you're going to lose that blood supply. And if you ever have a situation where systemically this perfusion is not very good, you can see how this could easily cause a problem in either this region or in the rectosigmoid junction. And ischemic colitis is the disease that typifies this pathogenesis we just talked about. And again, we have our rectosigmoid junction highlighted here. And so more distally to the rectosigmoid junction, you'll have your rectum. And what I'll do is I'll change it to a slide where we can see everything. So here's our rectum I've circled. You have your upper anal canal. You can see the lower anal canal. And dividing the upper and lower anal canal is something called the pectinate line. And as I alluded to, the pectinate line is probably the most important thing that you need to be aware of when you're studying this section. This line divides your endoderm and your ectoderm. And so what does that mean? So remember, when you look at embryologically how our GI tract is forming, we have our embryologic foregut, midgut, and hindgut. And the pectinate line will help divide this hindgut from a different type of tissue. So here's our hindgut I've circled, which will have our rectum and our upper anal canal. Keep in mind, though, that we have other tissue that's not technically part of our embryologic GI tract that needs to connect here. And this will comprise our lower anal canal. And this line right here that divides these 2 different embryologic regions is known as our pectinate line. This is from our GI tract introduction lecture, where I talk about the foregut, midgut, and hindgut. And notice here that in the hindgut, we mentioned that the rectum is involved, but I also told you that some parts of the GI tract, like the lower anal canal, are not technically part of the embryologic GI tract. And we've seen this earlier in our lecture series when we talked about the esophagus, how the proximal half of the proximal 2/3 of the esophagus is made up of different type of tissue, namely that non-keratinized stratified squamous epithelium. And whereas the distal esophagus, as you can see here, was comprised of glandular tissue like columnar cells. And that's because that was part of our our embryologic GI tract in the foregut. The same thing's happening here, where our rectum and our upper anal canal is a part of our hindgut. So it's going to receive a distinct nerve supply, lymphatics, and all that. Whereas distal to the pectinate line will have a different epithelial composition. And let's go over all of that now. And again, just as I was saying, the tissues above and below the pectinate line are going to have unique origins, and so therefore they'll have unique blood supply, lymphatics, innervation, and some clinical conditions. So let's break this down in a chart. So when we talk about the artery that's going to supply the region above the pectinate line, it's going to be the superior rectal artery, which is a branch off of the inferior mesenteric artery. Now, the inferior mesenteric artery should not surprise you, because remember when we were talking about the foregut, midgut, and hindgut, whenever we talk about the hindgut, the artery supplied was always the inferior mesenteric artery, and this is no exception. On the other hand, if you look at the region below the pectinate line, such as the upper anal canal, that region is going to be supplied by inferior and middle rectal arteries. And those arteries are not branch points off of the IMA. Instead, they are branch points off of your internal iliacs and your internal pudendal arteries. So let me show you the difference in this diagram to the right here. So if we look at above the pectinate line, so remember this is part of our hindgut, and because it's part of our hindgut, you're going to start, the blood will start from the inferior mesenteric artery and ultimately reach this superior rectal artery. On the other hand, for the regions that are below the pectinate line, these regions will be supplied by your internal iliac artery and followed by your internal pudendal artery before reaching either the inferior rectal artery or the middle rectal artery. And notice the middle rectal artery can sometimes branch directly off of the internal iliac. But the point I'm making here is that above the pectinate line, it's always going to be a hindgut organ, so it's going to be supplied by the IMA, and below the pectinate line, it's going to be through an entirely different blood supply pathway. So when we talk about the venous drainage of these regions, they're going to essentially take the same route they came in. So what do I mean by that? Well, we just saw how the artery came from the IMA into the superior rectal artery. So in this case, we're going to go out from the superior rectal vein to the inferior mesenteric vein. And what I want to mention is that the inferior mesenteric vein is attached to your portal system. So that will drain into the splenic vein and ultimately your portal vein. On the other hand, if you look at the veins below your pectinate line, you're going to have your inferior or middle rectal veins draining into your internal pudendal vein, which will drain into your internal iliac, your common iliac, and your IVC. And again, this is the exact same route in reverse. If instead of the IVC, we think about the aorta, which would drain into your common iliac artery, your internal iliac artery, internal pudendal, and finally your internal rectal. So your inferior rectal, excuse me. So these all are just the reverse of what the arterial supply just did. So let's talk about those in a diagram again. And I'm going to use the exact same diagram. We're just going to assume that these are now veins to make it easier for you guys. So let's talk about what happens above the pectinate line. So you're going to have your superior rectal vein, which will drain into your inferior mesenteric vein. And the only caveat here, the only difference is that because you're part of your embryologic GI tract, it's going to drain through that special portal system. So what does that look like? Again, you have your superior rectal vein draining into your inferior mesenteric vein. And as part of the portal system, that will all drain into the splenic vein. And finally, it'll reach the portal vein where it can be metabolized by the liver. It'll go through our central vein into our hepatic veins, and then finally reach our IVC. Like we're going to see this many times when we look at the liver section coming up later on. On the contrary, if you have tissue that's below the pectinate line, the veins will drain through the inferior or middle rectal veins. In the case of the inferior rectal vein, it would drain into the internal pudendal, then the internal iliac, the common iliac vein, and then the IVC. And notice I'm just using the arterial supply to just show that the venous equivalent to that would be the drainage, to make it easy for you to understand. That way you only have to learn one pathway, whether it's the artery or the vein, and then you can just reverse it conceptually and you'll know the pathway. Now for these next 4 features of the pectinate line, it's a little bit easier to remember it with this mnemonic. And the mnemonic that I think about when I go through this is that when you consider the area that's below the pectinate line, such as your lower anal canal, what's going to happen is that that area is closest to the surface. It's closest to the outlet. And so when I think about the lymphatics, the innervation, the cancer subtype, and the type of hemorrhoid, when I'm thinking about which is which, I always think about which of the named features sounds closest to the surface. And so let me explain what I'm talking about as we go through this. So for the lymphatic blood supply, if you're above the pectinate line, you're pretty far away from the surface. So those tissues are going to drain to the internal iliac lymph nodes. On the other hand, if you're below the pectinate line, those regions drain to superficial inguinal lymph nodes. And again, if you think about the name internal versus superficial, it's pretty obvious which of these two sounds like they're closest to the surface. So the superficial lymph nodes, to me, sound closest to the surface. If we talk about innervation, if you're above the pectinate line, it's going to be innervated through visceral innervation, whereas below will be innervated with somatic innervation. And again, the difference between visceral and somatic, if we go back to our GI intro lecture, where I talk about intraperitoneal versus retroperitoneal organs, I discussed these differences. And the visceral peritoneum was this region right here that I've highlighted in purple that surrounds the organ directly. And it has the same autonomic nerve supply as organs. On the other hand, the parietal peritoneum surrounds the abdominal cavity. So it surrounds all around here. And it has somatic nerve supply. And so when I think of visceral innervation versus somatic innervation, you can see how these somatic nerves are generally much closer to the surface compared to visceral innervation. So when we talk about the different types of cancers, if you look above the pectinate line, you'll see adenocarcinoma predominate, whereas below the pectinate line, you'll see squamous cell carcinoma. And this is the same thing we saw in the esophagus lecture, where the region that was closest to the oral cavity and outside of the GI tract we'd see squamous cell carcinoma, whereas we delve deeper inside of the GI tract, essentially further away from the surface, we started to see adenocarcinoma because those cancers were arising from tissues that were a part of our embryologic GI tract. And again, here's our GI tract subdivisions that I've shown you a few times now. We have our foregut, midgut, and hindgut, but we definitely had regions here that were not part of our embryonic GI tract. And all these regions are prone to the squamous cell carcinoma instead of that adenocarcinoma. And when we look at what type of hemorrhoids are going to form in each of these regions, above the pectinate line, you're going to get internal hemorrhoids, whereas below the pectinate line, you're going to have external hemorrhoids. And again, the name kind of speaks for itself. An external hemorrhoid sounds much closer to the surface. And that's why I like this mnemonic, because it holds true for each of these 4. And then these 2 things, you can just, like I said, as long as you remember one of the pathways, let's say the arterial supplies for both of these, you'll know the venous supply is essentially just the reverse, and you just have to switch most of the time, you just have to switch the artery to the venous equivalent. So let's move on to physiology. This will be our shortest physiology section by far. I just want you to know that the rectum and anal canal has some responsibility with electrolyte absorption, and then obviously it's useful for stool excretion. There's nothing really step 1 or level 1 is going to test you on that you generally need to know about rectal and anal canal physiology. they really like to emphasize the anatomical relationships, especially with that pectinate line that we talked about more. So let's move on to clinical conditions. So the clinical conditions, just as a heads up, the rectum-specific clinical conditions are extremely easy to remember, so this shouldn't be a big waste of your brain space. So we'll go over these four here. What I wanted to also add in, I'm going to talk about diarrhea, namely acute diarrhea versus chronic diarrhea. And then I'm also going to have a brief section on GI bleeding. And in order to make this a good use of your time, what I tried to do is I tried to use a question and answer format for the diarrhea and the GI bleeding sections, kind of like I did in the oral cavity, just to give you more of an integrated framework as to what to expect on a test if you see somebody with diarrhea or if you see somebody with GI bleeding. I wanted to show you how some of the conditions that we've either talked about already or that we're going to talk about later on in this unit might show up on a clinical vignette. But before we get to that Q&A section, I'll briefly talk about the four rectal or anal canal specific diagnoses that they want you to be aware of. So when we're talking about hemorrhoids, what they're really going to do on test is they're going to make sure that you know the different features between internal and external hemorrhoids. As we just talked about, an internal hemorrhoid is located above the pectinate line, whereas external hemorrhoids are located below the pectinate line. And here's the chart we just looked at where we have our internal hemorrhoids here and our external hemorrhoids here. And you can remember that because the external hemorrhoids, the name external just sounds closest to the surface. When we talk about innervation, it shouldn't surprise you that because you're above the pectinate line, you'll have visceral innervation. And when you're below the pectinate line, you'll have somatic innervation. And the reason why I wanted to point this out is that when you have visceral innervation, you're less likely to feel a sharp localizable pain. You'll feel more of that broad diffuse pain. And whereas somatic innervation, like if you pull a muscle in your body, you're going to have very sharp localizable pain. For that reason, if you take an external hemorrhoid, it's often going to be very painful or itchy because you're going to have that somatic innervation telling you exactly where it's hurting. On the other hand, internal hemorrhoids tend to bleed more, whereas external hemorrhoids tend to bleed less. In real life, you can obviously have an external hemorrhoid that's bleeding. You can also have internal hemorrhoids that are painful. But what I want you to know for step one is that they're going to keep this very straightforward to you. Internal hemorrhoids in your mind should just be non-painful bleeding. Those are the features of internal hemorrhoids. Whereas external hemorrhoids are going to be very painful, but they will not bleed. So keep this distinction in mind. And this shouldn't be difficult for you to remember as long as you remember the visceral and somatic innervation of anything above and below the pectinate line, this all should intuitively make some sense. Now let's briefly discuss anal fissures. So anal fissures are caused by tears in the anal mucosa below the pectinate line. And so this could be caused by a low fiber diet or constipation. So it's that repeated straining can cause some damage in this region. And so since we're below the pectinate line, we know that it's going to involve some sort of somatic innervation. And somatic innervation, if there's any damage to your somatic nerves, you're going to feel it. So it will be very painful. So in this case, you'll have pain while using the restroom. I just wanted to mention, in the case of anal fissures, because you actually have an anal mucosa tear here, you will often see blood when wiping. And something that's occasionally tested on step one, as well as it could be tested on your surgery shelf or step two occasionally, they like you to know that for anal fissures, the most common location for an anal fissure is the posterior midline. So if you look at your anal mucosa like a clock, it'll be that 6 o'clock position. And that's due to poor perfusion in that region. So I'll just quickly draw a diagram. If this is our if this is our anus here, and so if you look at it like a clock, so we have 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock, the most common location of an anal fissure here would be in the 6 o'clock position. And my mnemonic to remember this is that when you think of PU, like after you're using the restroom, you'll remember that it's the posterior location and it's under. That reminds me of the posterior midline right here. Let's move on to anorectal varices. So the pathogenesis of these, you'll have portal venous congestion or hypertension. All that portal congestion will back up in your portal system. And so you're going to get a backup in the superior rectal vein. Because there's a connection between your superior rectal vein and your middle and inferior rectal veins, some of that hypertension and congestion will be brought back. There's going to be a back pressure, which will start filling up those veins. Once these inferior and middle rectal veins become dilated, they're not going to be able to withstand these pressures because they're not used to having such high pressures in their small veins. And those veins itself can dilate and rupture, resulting in GI bleeding. And again, this is just caused by, this whole process will be caused by this vein here, this superior rectal vein actually attaches to the inferior and middle rectal veins. And so if there's a back pressure here, you can get some of that congestion building up here. And so let me show you. This is a diagram I use when we talk about this in great detail. In the liver section, I go over portal hypertension and all of its complications. So what ends up happening, what I want to mention to you is the framework that we're going to talk about. In the portal system, we have all of our portal venous fluid drains into our liver, and that goes to our hepatic vein and into our IVC. On the other hand, systemically, you'll have your classic artery that becomes an arteriole. Those drain into capillaries, which drain into venules. Those go into large veins and ultimately into the IVC. So what I'm going to do now is I can actually simplify this. And we have our portal vein ultimately drains into our IVC, and all of our other systemic venules and veins also drain into the IVC. So sometimes in a few different regions of our body, we actually have connections between these two systems. And so in those settings, if you have a enlarged portal vein in the setting of like portal hypertension, what can happen is that they can transmit some of that congestion to your systemic circulation. And that's why it's called a portosystemic anastomosis. And again, this is from our liver section. I talk about the 3 clinical conditions that you have to recognize, the 3 anastomoses you have to recognize, including their venous supply from both the portal system and the systemic circulation. And in this case of anorectal varices, we've talked about the portal supply is our superior rectal vein, and all that congestion can be transmitted to these inferior and middle rectal veins. And so what that'll look like is you'll have your superior rectal vein becoming very congested, and that can transmit it to these other veins, and that could ultimately cause bleeding if these veins cannot handle these new dilations. Okay, so anorectal cancer is our last rectum-specific conditions we'll talk about. You can get squamous cell carcinoma if it's below the pectinate line, and it'll be referred to as an adenocarcinoma if it's above the pectinate line. And again, that shouldn't surprise you. That's the same thing we've went over earlier. If it's above the pectinate line, that means it's part of your hindgut, it's part of your embryologic GI tract. And so it should come as no surprise to you that any cancer in that area would be an adenocarcinoma. On the other hand, if it's below the pectinate line, it's not part of your embryologic GI tract. So it's kind of similar to your oral cavity or proximal esophagus in that regard. And so if there is a cancer that forms there, it's more likely to be squamous cell carcinoma because the predominant cell type in that area is squamous cells. So some risk factors they want you to know for the test. They want you to know that HPV is a very big risk factor for, especially for squamous cell carcinoma. Anybody who has anal receptive intercourse is at risk. It's essentially the same reason why you're at risk for squamous cell carcinoma in your esophagus. It's that repeated inflammation and damage. And so the same thing can happen in the setting of anoreceptive intercourse where you have chronic inflammation and that can lead to cancer. Anybody who's immunocompromised is also at risk here. And the reason being that HPV, like we said, if HPV is a common trigger for squamous cell carcinoma of the rectum, then anybody who's immunocompromised might not be able to clear that virus as effectively. And so they'd be at higher risk as well. So that's it for the rectum specific conditions, but I wanted to take this time, since this is a little bit of a shorter unit, to talk about some things that may not be emphasized in a lot of the other review resources. So I wanted to take some time and talk about diarrhea and GI bleeding. So let's start with diarrhea. So the definition of diarrhea, it's a little bit vague, but just know that you can either have decreased stool consistency or an increased number of stools. If you have either one of those, you can technically meet the criteria for diarrhea. I want to talk about when you see a question on a test about diarrhea, I want you to immediately categorize it into a few different things. So the first thing I want you to do when you see somebody who has diarrhea, I want you to see how long they've been having it for. And when you look at that, then you'll be able to categorize it. Is it an acute diarrhea, which is diarrhea lasting less than 2 weeks? Or is it chronic diarrhea, which is diarrhea lasting greater than 4 weeks? I wouldn't worry so much about that subacute, that 2 to 4 week span. Just categorize it like this. And almost every test question you'll see, they'll be very explicit. Like, hey, this has been going on for 4 days, or this has been going on for 2 months. They're not going to try to trick you with that. Later on, when I talk about chronic diarrhea, we'll go over some of the composition. So when you see somebody with diarrhea, you're first going to look at, okay, how long has this been going on for? Once you've done that, I want you to try to get any features about, is this an inflammatory diarrhea or a non-inflammatory or some other thing? And we'll go over each of these compositions in a little bit. You can get inflammatory diarrhea where it's filled with blood, mucus, white blood cells. You can get fatty or malabsorptive diarrhea. So you actually see like fat. You can get a positive fecal fat test. The stool might float. And finally, you can get a non-inflammatory or a watery diarrhea. And this can be caused by a few different things. You can get an osmotic watery diarrhea. So that's where you have like a solute. So for example, if you think about something like lactose intolerance, you might have too much of that lactose staying in your GI tract. Water will come in and drain it. You can get a secretory diarrhea where basically you don't have any osmol in your lumen, but your body, for whatever reason, is just throwing all the fluids and electrolytes into your GI lumen, causing a diarrhea. And finally, you can get a functional diarrhea, which basically means like you have diarrhea, but we don't understand why it's happening. There's no real organic cause to it. So just kind of taking a step back, I'm going to go over each of these later. But for now, just remember, when you see diarrhea, think about how long it's been going on for, and then start to try to figure out, I wonder what type of diarrhea this might be. And as I go through this lecture, you'll be able to more easily categorize these specific subtypes. So I'm just going to talk about some of these stool studies. Some of them are more important than others. And for step one specifically, they don't try to emphasize too much about, they don't expect you to know all of these different stool studies necessarily to a T, or they don't really emphasize it too much on a test, but I still think it's useful for you to understand. So as the name suggests, on this slide, it's going to be pretty straightforward. Your stool white blood cells will literally just detect your white blood cells in your stool. I'm going to talk about another test later called fecal lactoferrin, which is actually a little bit more accurate in assessing whether there's any inflammatory cells in your stool. Your fecal occult blood test will detect blood. Your stool, ova, and parasite detects parasites like helminths, and your fecal fat test will detect fat. So those are the ones you've probably heard of before. Now I'm going to give you 4 stool studies that you might not have been familiar with. So let's go over those while we're here. The D-xylose absorption test will differentiate different causes of malabsorption. And it's technically not a stool study, but I like to put it in this category because I always want you to think about it in the setting of malabsorption. And I talk about this in the small intestine lecture, and I'm just going to re-go over the D-xylose absorption test now. It helps you to determine what is the actual cause of malabsorption. And because xylose is a monosaccharide, you only need a functional in small intestine for xylose to be absorbed correctly. So for the test, it's very straightforward. You give them some of that monosaccharide, you give them D-xylose, and then you measure their urinary D-xylose levels. And what'll that do? Well, if the D-xylose is correctly, let's say you have D-xylose and it's absorbed in your cells and it goes into your bloodstream, you're going to end up excreting some of this out in the urine. So if you detect any D-xylose in your urine, that'll tell you that the D-xylose was correctly absorbed, and that means that this intestinal region here is working just fine. Because remember, that's the only thing you need for absorption of D-xylose. And so if this is all working fine, then that'll clue you in to start looking at different regions that might be the problem of malabsorption, such as your pancreas, for example. And if D-xylose was not detected, then that means that this region must not be working because it's the only thing you need to absorb D-xylose. And so then you'll start focusing in more on an intestinal problem like celiac disease. And the reason I bring this up in a stool studies section, obviously this isn't related to the stool directly. Why I do that is because you're going to have diseases where they show some form of fat malabsorption. And once you find out that somebody has fat malabsorption, it's not like your problem is already solved right there. Then you have to start thinking, why do they have fat malabsorption? What's going on with that? Is it are there enterocytes damaged to where the fat micelles cannot diffuse in? Is it a problem with pancreatic lipases in the setting of pancreatic insufficiency? So this kind of points you in the right direction to figure out, I wonder why they have this fat malabsorption in the first place. So let's talk about another thing you might not have heard of before is the stool calprotectin. This is a calcium binding protein that you can find in neutrophils and granulocytes. And so it's actually useful to determine how much neutrophil activity might be going on within the GI tract. And as I alluded to before, this stool lactoferrin, it's useful. I remember the L in lactoferrin for the L in leukocytes. So it's a good marker of fecal leukocytes. And it's actually preferred over stool WBC count. The last thing I want to mention, which I don't recall it being tested heavily on step one, but I saw one resource that briefly mentioned the stool osmolar gap. So I thought since we're being comprehensive here and we should just go over it so you've at least seen it once. So what the stool osmolar gap will do is it'll help you differentiate between a secretory and an osmotic diarrhea. Recall from the very first slide I talk about with diarrhea, I told you to first assess it by timing, whether it's less than 2 weeks or greater than 4 weeks. And then I said, I want you to start thinking about the different compositions. And within my watery diarrhea, I had 3 different subtypes. I mentioned an osmotic diarrhea, secretory, or functional. So the good thing about this test is that if you ever get to this stage and they give you a stool osmolar gap, it'll help you differentiate between these 2 subtypes. So let's go over what is the stool osmolar gap. So what's happening? The stool normally is isotonic to plasma. And remember, our plasma is, we'll say it's around 290 to 300 milliosmoles. With that said, just because it's isotonic, just because it has the exact same concentration globally as our plasma, the individual concentrations of electrolytes will differ quite significantly between our stool and our plasma. So what we can do is we can essentially estimate the amount of sodium and potassium that we would expect to see in normal stool and calculate the gap from that. So what do I mean by that? So our stool osmolar gap is going to be essentially our expected concentration of our stool, which is 290. And what we can do is we can try to figure out how much sodium and potassium are in our stool to give us an idea of whether this is an osmotic or secretory diarrhea. And so if we just use this equation here, and I'll explain this. I know it's kind of confusing. I showed this on another slide, so it should make sense as we go forward. So what we're going to do is we're going to use this equation to figure out what would happen to the stool osmolar gap depending on our sodium and potassium concentrations. So if we had a ton of sodium and potassium excreted in our stool, that would make this number very, very, very large. And 290 minus a very large number is going to make this whole osmolar gap small, right? If you have 290, and let's say all of this adds up to like, 240, then your osmolar gap is only 50, which is actually kind of small. And so you'll get a decreased osmolar gap. What if you had decreased sodium and potassium excreted in your stool? So let's say you had low sodium and low potassium in your stool, and let's say this number, I don't know, added up to like 150, this whole number. So 290 minus 150 would be 140, which is actually a pretty high osmolar gap. So you can see the stool osmolar gap is going to be essentially the reverse of how much sodium and potassium you actually excrete in your stool. And so let me show that here. If you have excessive sodium and potassium excreted in your stool, we just mentioned that you'd have a decreased osmolar gap because this number would be very large, and 290 minus a very large number is going to give you a small number. So when would you ever have excess sodium and potassium excreted in your stool? Well, actually, let me talk about this first. I will go over that. So, and then on the contrary, we just talked about any decrease in sodium and potassium in your stool will give you a small number here. So 290 minus a small number, you'll still have a pretty close to 290, right? So it'll be a large osmolar gap. So now I want to kind of go back to what I was alluding to and talk about what scenarios would give you excessive sodium and potassium excretion into your stool. Well, that's going to happen in secretory diarrhea. And the reason it happens in secretory diarrhea is because for whatever reason, we'll talk about some of the mechanisms when we go over that Q&A section. In secretory diarrhea, what's happening is that your GI lumen is just throwing everything it can out into your GI cells, I should say, like your enterocytes are essentially throwing everything out into the GI lumen. And they don't care what they're throwing out. They'll throw out sodium, they'll throw out potassium. It doesn't matter to them. And so that's why you're going to end up getting a lot of sodium and potassium in your stool because there's no rhyme or reason to how much it's throwing out. And like we said before, just to reiterate again, if you have elevated sodium and potassium in your stool, this number gets very large. And so your stool osmolar gap in general gets very small. So you'll have a decreased osmolar gap. And you can see it in some of these conditions here. In a couple infections like cholera and ETEC, you can also see it in carcinoid syndrome and vipoma. On the other hand, so what would cause decreased sodium and potassium in your stool? So this happens, you have decreased sodium and potassium in your stool because you have a lot of other compounds present. So if you have a lot of other compounds present, that's gonna comprise most of this 290 here, this concentration. Instead of it being sodium and potassium, other compounds are in the stool that are helping to increase this number. And so what compounds would cause that? Well, anything that can cause an osmotic diarrhea could cause that. So instead of here in secretory diarrhea, everything's just getting thrown into the stool, including sodium and potassium. In the case of osmotic diarrhea, what's happening is that most of your osmoles are formed because of this, whatever you have in your GI tract, whatever is stuck there. It could be lactose in the case of lactose intolerance. It could be even fats in the case of fat malabsorption. And so all these different conditions here, what'll happen is that you're going to end up with some sort of osmol in your lumen. And because that'll comprise most of your osmolarity, you actually don't need any, you're going to have relatively less sodium and potassium excreted in this setting. Again, this right here, this stool osmolar gap, you might see a couple practice questions on it. And you may, if you do see this on the test, it'll probably be one question. So I don't want you to, if this is a little too confusing right now, that's okay. You don't have to know this specifically. I just want to give you a comprehensive framework so if you ever have to come back or if you ever hear about the stool osmolar gap in the future, you can at least come back here and try to learn it then too. So now that we've talked a little bit about some of the timing and the composition, what I really want to do is give you some question and answer format on how are you going to actually approach this. So let's start by talking about acute diarrhea. So again, acute diarrhea is going to be any diarrhea lasting less than 2 weeks. And what's going to cause it, especially on step 1 and level 1, it's going to be an infection. Now, in real life, you obviously can have chronic conditions that present acutely and then they go away and then they present acutely. Totally reasonable. When you're in a clinic setting and you have diarrhea lasting less than 2 weeks, sure, you should keep all those chronic causes of diarrhea that we'll discuss on your differential. But for step 1 and level 1, if the diarrhea is less than 2 weeks, it's going to be an infection. And so now that we know that's going to be an infection, how are we going to figure out what infection is what? So what I want you to do, it's very simple. I want you to figure out, is this a non-inflammatory diarrhea, like a watery diarrhea? Or is this an inflammatory diarrhea? And so based on this, you'll be able to categorize in your brain which condition is more or less likely, whether it's inflammatory, where it has, you see blood, you see mucus, you can have fevers, you'll see white blood cells in the stool, or lactoferrin if they measure that, or calprotectin for that matter, but more like, or you'll see a non-inflammatory or a watery diarrhea. So what I want to do is break these down and kind of give you a little bit of that question and answer format, and so that you can be prepared for some of these on the test. So let's first talk about the watery diarrheas, the watery acute diarrheas, and we'll start with some viruses. So what do you think the virus would be if you had gastroenteritis in a young child? This is associated with daycares, and the vaccine is associated with intussusception. So this would be leaning you toward rotavirus. On the other hand, what if you had gastroenteritis and it could be anybody, any age? It's most common in the winter months, and they love this association with cruise ships. So that would be norovirus. Moving on to some bacteria. If you saw watery diarrhea after travel, they love it. Travel to Mexico specifically. It has the nickname Montezuma's Revenge, and there's 2 enterotoxins that you need to recognize. This is ETEC, enterotoxigenic E. coli. And my next question while we're here is whether you know the 2 enterotoxins that are associated with ETEC. So those 2 are the heat labile toxin, also known as LT, and the heat stable toxin, also known as ST. And so how does the heat labile toxin work? So what is its mechanism of action? So its mechanism of action actually is that it activates adenylate cyclase. And what that'll do, that activation of adenylate cyclase, will end up promoting the secretion of chloride and water into your GI lumen. On the other hand, the heat stable toxin mechanism of action is a little different. This will activate guanylate cyclase. And guanylate cyclase, if you activate this, it'll actually decrease your ability to reabsorb sodium chloride and water. And so it'll be stuck in the GI lumen. And in both of these cases, you'll get that diarrhea for different reasons, though. And so a couple mnemonics that you might have been familiar with regarding how to tell the difference between LT and ST. Sketchy uses the mnemonic. They show that picture and they show El Agua de San Gabriel, where they look at the L and the A go together. So that'll tell you that LT activates adenylate cyclase, and the heat stable toxin, which is ST, will activate guanylate cyclase. My favorite mnemonic for this, I think I saw it in first aid, I could be wrong though, is labile like the air, stable like the ground. And that always helps me remember that the LT is associated with adenylate cyclase activation, whereas the stable toxin, the ST, is associated with guanylate cyclase, the G. So whatever works for you to remember this, but this is definitely tested. Okay, so let's move on. So what if you have a curved rod? So what is this? So you have a curved rod. It is responsible for significant rice water stools after travel to Asia. It's treated with oral rehydration therapy. So this is cholera, so by the bacteria Vibrio cholerae. And so the cholera toxin, what is its mechanism of action? They do test this quite a bit too. So this will activate adenylate cyclase. And what that does is it'll secrete fluoride and water into the GI lumen. And hopefully this should look very similar. This is the exact same mechanism of action that we just saw in the heat labile toxin of ETEC. So if you see, I've highlighted it here. And if we go back to the LT, the heat labile toxin, exact same mechanism. So sometimes they'll give you an example where you know it's cholera, and then they'll ask you, they'll say, this toxin has the same mechanism of action as the toxin of which other pathogen, and then they'll list off a bunch. And in this case, you'd have to pick ETEC, or you'd have to pick the toxin. They might ask you what's the toxin, and you'd have to pick LT, heat labile toxin. So what if you had nausea, vomiting, and diarrhea after consuming unrefrigerated meats, dairy, or baked goods? Oftentimes in the question stem, multiple people will be affected because it'll be at something like a picnic or a fundraiser. So this is Staphylococcus aureus food poisoning. How about if you saw a question that had watery diarrhea associated with reheated rice, and there's 2 enterotoxins associated with this bacteria. So that reheated rice should be a buzzword for Bacillus cereus food poisoning. And the 2 enterotoxins that are associated with B. cereus are the diarrheal enterotoxin and the emetic enterotoxin. So let's talk about some more bacteria. What if you see somebody who has watery diarrhea that starts after a prolonged hospitalization? I hope you're thinking about Clostridium difficile, so C. diff infection. And a few medications that are associated with C. diff. This can go a lot of different ways, but clindamycin is heavily tested. You can get cephalosporins, not as heavily tested, but in practice, you'll see more C. diff because of cephalosporins compared to clindamycin, mostly because cephalosporins are just used so much more as well. You can see it in ampicillin, fluoroquinolones. You can also see it in PPIs. So what I want you to remember from this slide, definitely they love to test this clindamycin, but just remember that pretty much any antibiotic is a possible contributor. And then for PPIs, we did talk about this in the stomach lecture when I talk about PPI pharmacology. I just want to remind you that that decreased acid in the gastric lumen will allow some of the bacteria to proliferate. So you're at risk of several different either bacterial overgrowths, or you're at risk of different infections because of that. That's a little bit lower yield. I just wanted to have a little bit of a callback though to something we talked about in the stomach lecture. So now let's talk about what watery diarrheas might form due to certain parasites. So what if you saw somebody with foul-smelling diarrhea and steatorrhea, which just means fat in the stool, and it's associated with outdoor water consumption and like a camper or a hiker? So this is talking about Giardia lamblia. And so how many trophozoites? Sorry about that. The trophozoites of Giardia, how many pairs of flagella do they have and how many nuclei? So they usually have 4 pairs of flagella and 2 nuclei. And if we look at a picture, those 2 nuclei kind of give you this classic, almost looks like a face looking at you. And they do like to show the histology so that you know that this specifically is the trophozoite of each Giardia. What if you saw somebody who has HIV and AIDS and they end up presenting with profuse watery diarrhea and they haven't been taking their antiretroviral medications? This parasite is associated with contaminated food or water sources. So that's going to be something called Cryptosporidium. And you can diagnose this. There's a few different ways, but a way they like to test it, they want you to know that this specifically can be diagnosed on stool. If you do a stool O&P, it'll stain acid fast positive. And you can treat it. The one you should probably pick on a test is nitazoxanide. It's an FDA-approved medication for cryptosporidiosis. Spiramycin might be mentioned, but if both of these are provided, I would definitely pick nitazoxanide. So that was just a quick framework about all the different causes of acute watery or non-inflammatory diarrhea that might be presented on a clinical vignette. I might have missed some, so just keep in mind on that. Like when I go through all these Q&As, whether it's acute diarrhea, chronic diarrhea, GI bleeding, I try to be comprehensive with it, but if it may or may not be exhaustive. What I want to do now, though, is talk about all of the causes of acute inflammatory diarrhea that you're likely to see on test day. So what's the most common cause of infectious bloody diarrhea in the US? This bacteria is a curved rod. It's associated with undercooked poultry and meat, and it may cause Guillain-Barré syndrome. This is Campylobacter jejuni. How about what if you see somebody who has bloody diarrhea after consuming undercooked beef? It has a classic O157H7 variant. It's associated with hemolytic uremic syndrome. It has a Shiga-like toxin, and it does not ferment sorbitol. This is enterohemorrhagic E. coli, or EHEC. What if you had watery or sometimes bloody diarrhea in children? It's in the same class as EHEC and ETEC. This is less tested, but this is your enteroinvasive E. coli, so EIEC. And the last one I have on this slide, bloody diarrhea in an infant or child, strong associations with daycare, pork, and unpasteurized milk, and it can cause something called pseudoappendicitis. This is Yersinia enterolytica infection. How about a bloody diarrhea or fever after recent travel to either India? India is very heavily tested on this disease, but it could also be somebody traveling to China or Africa. This bacteria invades your pyre patches, and you need a very large inoculum. So you need a lot of this bacteria to enter your GI tract to become infected. This is a Salmonella typhi infection. What's the macular rash that it's seen in about 30% of individuals with a Salmonella typhi infection? So those are called rose spots. So they might give you that as a symptom as well in order to increase your likelihood of picking Salmonella typhi. And if you have chronic Salmonella typhi, what are you at increased risk for regarding cancer? So that's actually gallbladder carcinoma. And when we talk in our hepatobiliary unit later on, you'll notice that one of the risk factors you'll find is this chronic Salmonella typhi infection. So what if you have somebody who, it's the same family that we've been talking about here, and they present with gastroenteritis and non-bloody diarrhea. This is associated with undercooked poultry and pet reptiles. So this is Salmonella enteritidis. And keep in mind, this is not technically an acute inflammatory. This one right here, it's a non-bloody. So this is actually a watery diarrhea. I just wanted to put it in here just so you can see the two differences between the different subtypes of Salmonella that they like to test. And again, this is just a question more broadly related to Salmonella. So Salmonella osteomyelitis, they want you to know what if you see somebody with Salmonella osteomyelitis, what comorbid condition may they have? And they like the association. If somebody has sickle cell disease, they're at increased risk of Salmonella osteomyelitis. Now, I want you to understand this distinction as well. So people with sickle cell disease can get Salmonella. So if you see somebody with Salmonella osteomyelitis, you should pick sickle cell disease. With that said, if somebody has sickle cell disease and they develop osteomyelitis or they develop a septic joint, what's the most common contributor? A lot of people here think the opposite is true, and so they want to pick Salmonella. It's actually not. Staph aureus is your most common cause of osteomyelitis in pretty much any disease condition. That doesn't mean you can't get salmonella from if you have sickle cell disease. It's definitely a risk factor, but still, your most common cause of osteomyelitis in a patient with sickle cell disease is still going to be Staph aureus. What if you find somebody who has bloody diarrhea after travel or after some sort of contaminated food or water exposure? This, similar to salmonella, will invade your Peyer's patches, so those M cells. But in contrast, you're going to require a very low inoculum. So this thing is very infectious and it produces an eponymous toxin. So the toxin is the same name as the disease itself. So this is your Shigella. This is Shigellosis or from Shigella sonnei. And so it has a Shiga toxin. And so what's Shiga toxin's mechanism of action? So what it does is it'll invade the 60S ribosome, and if you invade that, you're going to inhibit protein synthesis. And I wanted to mention, again, similar to how we saw that with cholera and ETEC, we also saw this with in my oral cavity lecture, I talk about diphtheria and how diphtheria's toxin has the same mechanism as Pseudomonas exotoxin A. They really like you to know if something has a similar mechanism of action. So in the case of Shiga toxin, what's the other toxin that has the exact same mechanism of action? It's going to be the Shiga-like toxin, and that's part of EHEC, enterohemorrhagic E. coli. So here's EHEC. We talked about this earlier. You can see this Shiga-like toxin. And so this does the same thing as the Shiga toxin that we're talking about now, namely inhibiting that 60S ribosome, which will inhibit protein synthesis. So yeah, just again, diphtheria and Pseudomonas exotoxin A, remember those two. Remember cholera, and remember ETEX, heat labile toxin with that adenylate cyclase activation. And then finally, remember this one, the Shiga toxin of Shigella, as similar to the Shiga-like toxin of EHEC. Okay, so what if you had a parasite now that's causing bloody diarrhea, flask-shaped ulcers, and this parasite may form abscesses in your liver, lung, and brain. So this is Entamoeba histolytica, and I talk about this in the liver section. So if you don't know that yet, that's okay. I'll just show you kind of how it works. So most of the time, 90% of the time actually, Entamoeba will become non-invasive. And so how that works is that you have an Entamoeba cyst, it'll mature into a trophozoite and attach to your intestinal wall. And then basically this won't invade, it'll just produce a bunch of cysts that can reinfect other people. Now, this is the most common subtype. This happens more often if you do get infected, but they're not going to test this because this is not unique. What's unique about Entamoeba is that about 10% of the time you can get invasive disease. And so what happens there is that cyst will mature into a trophozoite, and that'll attach to the intestine and it'll actually invade. And so as it invades the intestine, it'll form these classic flask-shaped ulcers. And as it invades, you'll also get that bloody diarrhea that I was just talking about because of that intestinal mucosa damage. So these trophozoites will enter your bloodstream and they can consume red blood cells. They also may develop abscesses in your liver, lungs, and brain. So just keep that one in mind. And especially they'll always mention this bloody diarrhea, and that's because it's actually invading your intestine. On microscopy, I kind of gave this away. It's going to show you trophozoites with engulfed red blood cells. So here's a picture that I mentioned in the liver section. You have these red blood cells inside of the trophozoite. They like you to know the intraluminal agent that you need to kill the cysts of Entamoeba. And so I'll give you those right there, the idonoquinol and paromomycin. And you can use metronidazole to treat a systemic Entamoeba infection. And I'm just going over this just to give us at least one opportunity, and this will be from the liver lecture, excuse me. I wanted to talk about metronidazole at least once in this lecture, since there's a lot of these bugs that might respond to it. And so The good mnemonic that I've seen, I can't remember where this was from, but I do like this one. It's get gap on the metro. So the metro will remind you of metronidazole, and this get gap, if you've ever seen, like, I think this is mostly in the underground in London, where you have this mind the gap at their metro stations. This will remind us of this get gap mnemonic. So the G stands for Giardia. The E stands for the entamoeba histolytica, which we're talking about now. You can also use metronidazole for Trichomonas vaginalis and Gardnerella vaginalis. Anaerobic infections tend to respond to metronidazole. And then H. pylori quadruple therapy also uses metronidazole. And here's from our stomach lecture. I just wanted to reiterate that metronidazole is used in that H. pylori quadruple therapy, excuse me. So that's enough talk about acute diarrhea. Let's transition over and discuss chronic diarrhea. So again, chronic diarrhea on a test, just look for any diarrhea that's lasted longer than a month. You can have inflammatory diarrhea and non-inflammatory. So what I like to do when I take the test is I'll keep it simple. When I see diarrhea, I think of the timing. And once I've done that, I think of whether it's inflammatory or non-inflammatory. It keeps it very simple. And you can do this in acute diarrhea. We just did this. We just talked about all the causes of watery diarrhea first, and then we just talked about all the causes of bloody diarrhea. So let's do the same thing here. The only difference is that once you've categorized it as this watery diarrhea, there's just a few more steps. You just have to figure out, okay, I know it's not an inflammatory chronic diarrhea. So what's happening? Is it a fatty diarrhea? Is it what kind of watery diarrhea is it? Is it that osmotic diarrhea, which is related to solutes in the lumen? Is it a secretory diarrhea where your enterocytes are throwing everything into the lumen? Or is it a functional diarrhea where we honestly don't know why it's causing what it is? So fatty diarrhea, I just wanted to show you some of the subtypes while we're here on chronic diarrhea. Fatty diarrhea, as the name suggests, it's related to fat malabsorption. So normally our fat is broken down into micelles, which can diffuse into the enterocytes. However, if you have fat malabsorption for whatever reason, these fat globules can end up continuing along your GI tract, and you'll excrete them in the stool, causing a fatty diarrhea. This will give you a positive fecal fat test, which shouldn't surprise you. They sometimes mention that the stool is foul smelling, or that the stool floats, or that the stool's greasy. So keep all those in mind to increase your suspicion for fatty diarrhea. Let's talk about the watery diarrhea subtypes. So the osmotic diarrhea is related to solute. So essentially you have some sort of solute, it's stuck in the GI tract, and because of that, water likes to follow solute, and so water is going to enter the GI tract and everything's going to be excreted. So because it's usually related to some sort of food intake that cannot be digested, you're going to notice osmotic diarrhea after meals. You're not going to see it at night though, because there's no solute in the lumen that's perpetuating this diarrhea. And you'll also see a high stool osmolar gap. And if I go back to the slide on stool osmolar gap, I mentioned that in the case of osmotic diarrhea, you have so much of this, whatever this solute is, you have so much of this solute in the lumen that there's not enough room for any sodium and potassium in that lumen as well. And because of that, if you have a decreased sodium and potassium excreted in the stool, you can get an increased osmolar gap. Let's contrast that with secretory diarrhea. So this is caused by active secretion of substances into your lumen. So if this is our lumen, you're going to have active secretion of all these water and electrolytes into the lumen and out into the stool. And so this will present as constant diarrhea, including at night. And that's an important distinction. Remember, osmotic diarrhea won't cause nighttime symptoms because there's nothing in your GI lumen that's promoting that release of water into the lumen and as feces. In the case of secretory diarrhea, it's through an entirely different mechanism, so you'll still get nighttime diarrhea. Another contrasting feature is that secretory diarrhea has a low stool osmolar gap. And so right here, because it's releasing everything, including sodium and potassium, into the GI lumen, this number, if this number gets very, very high, then you'll have 290 minus a very high number, and this will end up, the stool osmolar gap will end up being a lower number, namely less than 50. And for the increased osmolar gap, it should be at least in the low to mid 100s to be considered an increased osmolar gap. But they'll give you the numbers on the test, they'll give you whatever normal values they want. So I wouldn't worry too much about that. And then a functional diarrhea, I didn't have a slide specifically. It's mostly a diarrhea without an organic cause. So it usually suggests something like irritable bowel syndrome more than anything. So let's do the same thing that we did with the acute diarrhea and run some sort of question and answer type format for this. I didn't subcategorize the chronic diarrhea into each of these categories like this. The reason I didn't is because this is nice for studying, but sometimes they overlap more than you'd think. So, for example, somebody with a fatty diarrhea, that's technically going to cause an osmotic type of diarrhea anyways. So I didn't want to use this and confuse people even more. So with that said, we can still get a lot out of this question and answer type format here. Let's start with this one. You have chronic bloody diarrhea in a young adult. The disease is associated with skip lesions, the string sign, creeping fat. You can get fistula formation, and it is ASCA positive. That's describing Crohn's disease. And if we look at our inflammatory bowel disease lecture, this was our last lecture actually, you can see that you can get diarrhea. It can be bloody or non-bloody. They tend to have it be bloody more often than not. And here we have some features that are specific to Crohn's disease, like the string sign, your creeping fat. You have several different complications. So know the differences between Crohn's and UC when a question like this comes up, because that's usually what they're going to be testing you on. So what happens if you find somebody a chronic bloody diarrhea in a young adult again, but this disease now is associated with continuous lesions, it's P-ANCA positive, you have a risk of colon cancer or primary sclerosing cholangitis, you can see pseudopolyps or crypt abscesses. So now we're describing UC, and here are some features specific to UC that you need to be aware of. Again, think about that lead pipe sign, all these complications. So know the difference between Crohn's and UC for sure. What if you find somebody with chronic bloody diarrhea, fever, right upper quadrant abdominal pain, jaundice, and fatigue? They might mention onion skin fibrosis on a biopsy or a beads on a string appearance on a cholangiography. So now we're talking about primary sclerosing cholangitis, which is a potential complication of UC. So again, here's PSC. I talked about it a little bit in the UC section. You're going to see it as its own condition in the hepatobiliary unit. And notice that in addition to your ulcerative colitis or IBD symptoms, these bloody diarrhea, abdominal pain, and fever, in addition to that, you're going to see right upper quadrant abdominal pain, jaundice. So you're going to see some sort of biliary disease as well. And here you can see the onion skin fibrosis and the beating of the ducts. And I talk about that. I show pictures of both of those in the hepatobiliary unit if you want to learn more about PSC. What if you find a middle-aged female with diarrhea and abdominal pain associated with defecation? If you do any laboratory studies or colonoscopy, everything's negative, and this is often diagnosed by the Rome criteria. So now we're describing irritable bowel syndrome, or IBS. And here we go with IBS. I just wanted to point out, in the setting of chronic diarrhea that we're talking about, you can get diarrhea. So IBS-D would be diarrhea predominant IBS, and that's kind of what we're referring to here. And here's your Rome criteria. Always remember, they're going to mention this sort of pain related to defecation if they want you to pick IBS on a question stem of an individual with chronic diarrhea. So now, what if you have an adult female? You can occasionally have chronic diarrhea, sometimes with blood, sometimes without. It's more known for its association with iron deficiency. You can get anti-tissue transglutaminase positive on labs. Dermatitis herpetiformis is a known complication, and you need to restrict gluten as the treatment. So now we're describing celiac disease. What if you have a newborn child or child with failure to thrive? Again, you have that anti-tissue transglutaminase positivity, and gluten restriction is recommended. So it's not a trick question. I mean, I guess maybe it is kind of a trick question. This one's also celiac disease. I just wanted to let you know they usually presented on a test in this first case, but don't forget about this newborn or child with failure to thrive. As long as this lab value is shown, that should lead you to celiac regardless. And so here we go. You'll see diarrhea occasionally in the presentation. Now what if you had osmotic diarrhea after attending a pizza and ice cream social? So that's discussing lactose intolerance. How about if you had osmotic diarrhea in somebody who consumes dairy products after recovering from gastroenteritis? And again, that's describing lactose intolerance. And I go into more detail about lactose intolerance in the small intestine lecture. Just wanted to point out those two different presentations, either after consuming dairy products in general or more acutely consuming dairy products after GI illness in somebody who had no pre-existing intolerance before. And the last thing I want to mention on this slide is, if you know the mechanism by which consuming high sugar meals after gastroenteritis would cause worsening diarrhea. And so this can happen because we have a special enzyme called our sodium glucose linked transporter, SGLT1. And what this does, as the name implies, it will absorb glucose along with sodium. And so if you only consume glucose without any sodium, a lot of that glucose gets stuck in the lumen and causes an osmotic diarrhea. So this is from our small intestine lecture, and I point out that several of these monosaccharides use this SGLT1, and you need, for every glucose or galactose that enters, you need a sodium to enter as well. And that's why when you're rehydrating, you should give equal concentrations of sodium and glucose. And if you don't do that, if you just give them a bunch of glucose, a lot of that glucose will just stay in the lumen because you have a relative sodium deficiency in the lumen, and this will cause an osmotic diarrhea. Okay, so let's move on. What if you saw somebody with chronic diarrhea and somebody who recently visited the tropics and at that time developed an infectious diarrhea? It has an association with folate and B12 deficiency and can be treated with antibiotics. So that's discussing tropical sprue. And here we go. You can just remember that they have to mention some sort of visit to the tropics and some sort of infectious diarrhea. If they don't mention those two things, I would be very skeptical in picking tropical sprue. What if somebody had diarrhea, B12 deficiency? This disease is associated with PPI use and response to antibiotics. Kind of a tougher question. I talk about it when I talk about the Schilling test. This is also something you can do a Schilling test on. This is small intestinal bacterial overgrowth, or SIBO. And again, one of the one of the symptoms of SIBO is that diarrhea. How about if somebody had cardiac symptoms, joint pains, neurologic symptoms, diarrhea, and then if you actually did a biopsy, you'd find PAS positive macrophages in the lamina propria. Now we're describing Whipple disease. And here's from Whipple disease. My favorite mnemonic is for Whipple disease is the can of whip pass. So you have the can here, talking about cardiac arthralgias and neurologic symptoms. You have, because you're sitting on the can a lot, you'll have diarrhea as well. And then the whip will remind you of Whipple's disease. And then the PAS will remind you of that periodic acid shift positive foamy macrophages. And I talked about this in the liver section, what this periodic acid shift does. All it does is it measures complex compounds inside of your cells. So it can measure glycogen, it can measure glycoproteins, glycolipids. In the case of Whipple disease, it's measuring all the glycolipids that get stuck inside your intestines. And then we'll see later on in a disease called alpha-1 antitrypsin deficiency, these PAS actually measures all the glycoproteins, all these misfolded alpha-1 antitrypsin proteins that get stuck in your liver cells. And moving on, so what if you had diarrhea and steatorrhea? You have a failure to thrive. It's caused by deficient ApoB48 and ApoB100 protein production. And you'll end up with these lipid bubbles inside of enterocytes. Now we're talking about A-beta lipoproteinemia. And from our small intestine lecture, just wanted to jog your memory about how steatorrhea, or that fatty diarrhea, is one of the main symptoms that you're going to see. And you'll also they'll probably mention this sort of lipid bubbles inside enterocytes if they want you to pick this disease. And what if you found somebody who has diarrhea or fatty diarrhea in a patient with cystic fibrosis or chronic pancreatitis, pancreatic cancer, or somebody who had a pancreatic surgery? Your D-xylose absorption test would be normal in this disease. So now we're talking about pancreatic insufficiency. And again, fat malabsorption and steatorrhea, very common presentation of pancreatic insufficiency, and they will definitely give you one of these risk factors if they want you to go after this. Let's talk a little bit about some neuroendocrine tumors that can cause chronic diarrhea. So what neuroendocrine tumor will cause bronchospasm, flushing, diarrhea, and right heart symptoms? And it's diagnosed with a urine 5-HIAA level. So now we're talking about carcinoid syndrome. And here's our BFDR mnemonic that we use. And the diarrhea, so it's a secretory diarrhea, which means you'll have a decreased stool osmolar gap because everything's just being thrown into the lumen, including sodium and potassium. Keep in mind that elevated 5-HIAA level, they really love to test that in the urine. And this is from our small intestine lecture. The reason why that's so high is that once it's able to be metabolized in either your liver or your lungs, it'll be metabolized into this 5-HIAA compound, which ultimately gets excreted, so you can measure that in the urine. How about a neuroendocrine tumor that causes watery diarrhea, hypokalemia, and achlorhydria? That is a vipoma. We talk about this later in the pancreas section, this classic WDHA syndrome. So this tumor overproduces VIP, and it classically causes this watery diarrhea. And that's what if you've ever seen a textbook, almost every resource uses this WDHA syndrome for this watery diarrhea, hypokalemia, and achlorhydria. I don't really like this mnemonic as much. I like this. My mnemonic here is this vipoma is very important potty syndrome, because if you're having watery diarrhea and you're having significant vomiting, honestly, the only thing that would matter to you is this bathroom, and that helps me remember it's diarrhea. I go over this in the pancreas lecture, that anything with severe vomiting would cause hypokalemia and achlorhydria. So take a look at that. But just know for now, vipoma is associated with watery diarrhea, hypokalemia, achlorhydria. How about a neuroendocrine tumor that causes distal duodenal ulcers or proximal jejunal ulcers? It can sometimes cause chronic diarrhea. You diagnose it via the secretin stimulation test. So that's a gastrinoma, also known as Zollinger-Ellison syndrome, which we've talked about in the past. Just know these ulcers in the distal duodenum and know that the secretin stimulation test can help ascertain a diagnosis. The diarrhea on that one is a little bit more rare than most of the other tumors. These other two, for sure, as part of their classic symptomatology, will see diarrhea. This one, I'd more pay attention to the ulcers. They might give you the diarrhea, but this one's less important regarding the diarrhea specifically. How about this neuroendocrine tumor that causes diarrhea, necrolytic migratory erythema? They love that phrasing. Diabetes, declining weight, DVT, and depression. So this is the glucagonoma, which I also discuss in the pancreas lecture coming up later on. And there's the diarrhea. And honestly, on a test, if you ever see this necrolytic migratory erythema, strongly consider picking glucagonoma. All right, and what if you see somebody who has postprandial diarrhea and they get facial flushing after consuming large sugar-filled servings in somebody who had a recent gastrectomy or some gastrectomy in the past? So that's describing dumping syndrome, which we've already talked about. And all I want to mention here, I don't want to go over the entire pathogenesis, but basically you have so much solute here rushing into your intestines, and that'll form an osmotic diarrhea. So you'll get excessive diarrhea, and that's why you have to eat in smaller portions to avoid that. There's a vitamin deficiency that's classically associated with the 3Ds, dermatitis, dementia, and death, and that's niacin deficiency or vitamin B3. How about if somebody, these last two are pretty rare. I just put them in there just to be comprehensive. I don't really think you'll get tested on this too much, but what if somebody has recurrent gastroenteritis, sinusitis, otitis media, pneumonia? If there's an association with several autoimmune disorders, asthma, transfusion hypersensitivity. I think this is also associated with like false positive pregnancy tests, kind of random. This is actually IgA deficiency. And last one here, if you have a female who has palpitations, anxiety, heat intolerance, diarrhea, and a palpable neck mass, this might be tested. So this is hyperthyroidism. Let's go over some medications that might cause chronic diarrhea before we move on. So which antibiotics can cause it? Because you're altering your GI gut flora, pretty much any antibiotic could cause diarrhea. They like clindamycin and cephalosporins especially, and they like clindamycin for C. diff infection as well, as we saw. Actually, they like both of these for C. diff technically as well. Which gout medication is responsible for diarrhea? The microtubule inhibitor, that's colchicine. Which antacid has a strong association with diarrhea? Now we're talking about magnesium hydroxide. And from our stomach lecture, I mentioned that magnesium hydroxide causes diarrhea, and our mnemonic to remember that is that magnesium causes megafeces. You could also use aluminum hydroxide as an antacid, and that'll have the opposite effect. And our mnemonic is aluminum causes minimum feces or constipation. There's a few different classes of cholesterol meds that can cause diarrhea. The main ones that they want you to know are bile acid resins, ezetimibe, and fibrates. Bile acid resins we've talked about before, and the small intestine and the colon section. So notice here that bile acid resins, their job is to bind to these bile acids and inhibit their reabsorption. And so if you're losing a lot of this bile acid, then you can get a fatty. If you don't have any more bile salts, what'll happen is that future fat globules will not be able to be broken down, and instead they'll be excreted in the stool. So you get a fatty steatorrhea. You also are at higher risk with bile acid resins because you're losing your bile salt. You're at a higher risk of developing gallstones. I talk all about gallstones in the hepatobiliary lecture later on. What's the first line diabetes medication, and it has an association with lactic acidosis? That's metformin. How about the other diabetes medications? This one will inhibit carbohydrate breakdown into monosaccharides in your GI tract. These are your alpha glucosidase inhibitors, very, very well known to cause flatulence, bloating, diarrhea. The names, you can get acarbose or miglatol are two of the most common alpha glucosidase inhibitors. And finally, if you have diarrhea in a woman who has a high PHQ-9 score, has tried counseling and that didn't work, so you can give her an antidepressant. And so SSRIs, very, very commonly associated with a wide variety of GI side effects. Now we'll move on to GI bleeding, and we're going to do somewhat similar thing. So when you saw somebody with diarrhea, I wanted you to know the timing of the diarrhea, and I wanted you at least think about the composition of the diarrhea. That way it's easier to form your differentials. In the case of GI bleeding, I want you to think about the appearance of the GI bleed and what location you think that the GI bleed is coming from. So for appearance, you can either have melena or hematochezia. So melena is describing, they'll sometimes write it as coffee ground stools. They might also describe it as dark tarry stools. And the reason why it looks so black and dark is because what's happening is that the blood in your GI tract has had time to get digested. And so it'll change from the red color that we think about into this dark tarry stool. And this is more often associated with upper GI bleeding. And I'll talk about that in a little bit. Here is our GI tract. So let's say you have bleeding in your stomach, for example, like gastritis. As it goes through the GI tract, it's going to get digested, especially if it's up here in your upper GI tract. It'll have much more time to get digested. And by the time it is excreted in the stool, it'll show up as this coffee ground stool or this black tarry stool. On the other hand, hematochezia is going to show up as bright red blood per rectum. And this is more often associated with lower GI bleeding. So again, if you have, let's say you have bleeding here in your sigmoid colon from diverticulitis or something, diverticulosis, if this specifically will not have that much time to digest from here to the exit, and so you'll often see this presenting as bright red blood per rectum. Something I want to point out here, I mentioned that melena is associated with upper GI bleeding and hematochezia for lower. That's pretty safe for step 1 and level 1. I would use that almost 100% of the time. In real life, though, it's not as straightforward. You can get somebody, if somebody's bleeding extremely fast from your upper GI tract, extremely brisk bleed, you could end up still having bright red blood because the blood's moving so quickly through the GI tract that it's not being digested. So you can get somebody who has an upper GI bleed that actually has hematochezia. And on the flip side, you can get somebody who has a bleed in their, let's say just distal to the ligament of Treitz, which I'll explain in a second. Essentially, you can get somebody who has a lower GI bleed, but the blood has had enough time throughout the colon, at least, and parts of the small intestine to digest and form melenic stools, even though it's technically a lower GI bleed. But for the purpose of step 1, we're going to keep it simple. We're going to say, if you have some sort of melena, like this dark tarry stools, it's an upper GI bleed. If you have this bright red blood, it's a lower GI bleed. So let's talk about what those actually mean, upper versus lower. So an upper GI bleed is any bleed that's originating proximal to the ligament of Treitz. So in our small intestine lecture, we talked about the duodenum, and I broke down each of the 4 sections of the duodenum. And when I talked about the ascending duodenum, or the 4th portion, all I really wanted you to know is that there's this ligament of Treitz here. And so this will help differentiate, between an upper and a lower. So anything proximal, if we go to the proximal duodenum, and then this will go into the stomach, esophagus, oral cavity, all of that is an upper GI bleed. And on the flip side, if we go into our jejunum, ileum, colon, and rectum, those will all entail lower GI bleeds. And so how can you tell if it's an upper or a lower? So some things you can do with an upper GI bleed, it'll also show up with this hematemesis. So if you're throwing up blood, it's going to be an upper. You'll also get coffee ground emesis potentially, and as well as melena, which we've talked about. So here we go. The bleed originates proximal. So if this is our ligament of Treitz, approximately, anything proximal to this will be an upper GI bleed. You'll get hematemesis and coffee ground emesis because it's so close to your oral cavity that if you do throw it up, it'll be bloody. And the coffee ground emesis will happen, like let's say you have a bleed here and it goes down and it is able to get digested a little bit in the stomach before coming up. It'll look like coffee grounds in your throw up. And we've already seen this. The melena is if you have enough time to digest all the way through your GI tract, you'll get melenic stools. Something I didn't add, and it's not going to be tested on step 1, but you'll probably be pimped on it, and you'll notice it in wards, is that upper GI bleeds on laboratory findings are associated with elevated BUN levels. And that's because the blood has had enough time to go through your GI tract and get digested, and some of that digested nitrogen ends up entering your bloodstream, and you'll have an elevated BUN. And like I said, that's going to happen more often in upper GI bleeds, because in lower GI bleeds, let's say you have a bleed here, it's not going to have that much time to get digested and excreted out, so you won't get an elevated BUN in the process. So lower GI bleeds are originating distal to that ligament of Treitz, and they're going to present with hematochezia, or bright red blood per rectum. So again, if we have our ligament of Treitz, anything distal is considered a lower GI bleed, and hematochezia will happen because here we go, we have our bleed, and it's not going to have much time to digest, so it's going to still present as this bright red blood. You will not get an elevated BUN in a lower GI bleed because this has not had time to digest and the nitrogen hasn't had time to enter your bloodstream. So I'll just mention the GI bleed treatment in passing. This isn't tested on step 1, it's more of a step 2. That's why I'm kind of gonna breeze through it. What you're gonna do is you need to resuscitate them first. That's more important than anything else. So oftentimes you'll give 2 large bore IVs. So you can give like a 14 gauge, and to make sure that they're actually being resuscitated before you do anything. You're gonna type and cross them. You'll transfuse them if they need it. Oftentimes people use 7.0 as the cutoff, so less than 7 for a normal person, less than 8 with cardiovascular disease. But again, if somebody's like actively bleeding, like you know they're bleeding and they have a hemoglobin of like 7.8, you still might give them a unit, because as you replenish their fluids, you're going to find out that they're going to actually be more anemic than you initially thought. Again, that's kind of step 2 stuff. I wouldn't worry about that. You always give an IV PPI in anybody with GI bleeding. The reason you do this is because the gastric acid in upper GI bleeding, if it's a really acidic environment, it makes it more difficult to form platelet plugs and to stop the bleeding. So an intravenous PPI will help somebody if they have an upper GI bleed, and it won't really cause any harm if you have a lower GI bleed, but it won't really do anything good either. But that's why you just give it to everybody, because it'll help a certain percentage of those people who have upper GI bleeding. If somebody has liver disease, you should give octreotide and ceftriaxone. That's been shown to improve mortality in people with variceal bleeds. And you should obviously consult your GI doctor if they get admitted. Oftentimes they're going to do an endoscopy, and if that's unrevealing, they might consider a colonoscopy or angiography or tagged RBC scan. Again, I'm kind of breezing through this because it's really not the best information for if you're studying for step 1 or level 1. It's kind of one of those things that I just want you to hear once, just so at least you've been exposed to this material. And what I think you'll get the most out of is what I'm going to talk about next, because I go over a lot of the conditions we've already discussed throughout the unit in the context of how it would present in a GI bleeding case. So let's start with the oral cavity and some of the esophagus. So what if you had somebody who had melena in somebody who had profuse nosebleeds or epistaxis, or a recent dental surgery that had a lot of bleeding? This isn't a trick. This is literally, it's going to be that nosebleed or that, that oropharyngeal bleeding that you had during that dental surgery. That can easily go down your GI tract and present with this melenic stools. What autosomal dominant disorder is classically typified by recurrent nosebleeds and GI bleeding? I refer to it as genetic angiodysplasia. This is a disease called hereditary hemorrhagic telangiectasia, or HHT. Here's a picture of some of the telangiectasias you can see, and they can be throughout your GI tract, so it's very easy to get bleeding. Because it's an autosomal dominant disorder, if they want you to pick this, they're going to mention a family history of somebody else who has these exact same symptoms. And we're going to contrast this later with angiodysplasia, which is not hereditary, but it also causes like these tortuous vessels. I'll have that later on in this Q&A. So what is it called? What's esophageal inflammation called that will result in GI bleeding? That's just esophagitis. And I discussed this in the esophagus lecture. There's 4 causes that I kind of went over. And the most common would be acid reflux. You can get medications causing esophagitis. I also mentioned the eosinophilic esophagitis, where you get those linear furrows. And then infectious, we talked about the 3 different types of infectious esophagitis. Remember, this one causes like pseudomembranes and a fibrinous exudate. This one causes your punched out ulcers. And then this one causes your linear ulcers, because there's always a long line at the CMV. And speaking of medication-induced esophagitis, what medications are classically associated with this? You're going to see this in bisphosphonates, NSAIDs, and tetracyclines. And this is from our esophagus lecture. I've just highlighted these 3 right here: bisphosphonates, NSAIDs, and tetracycline. Let's talk about some more esophageal conditions, probably more high-yield ones than the ones we just talked about. What if you find somebody who has painless hematemesis and profuse GI bleeding? This is the most common cause of an upper GI bleed in somebody who has pre-existing liver cirrhosis. So these are your classic esophageal varices. And what portal vein and what systemic vein are involved in esophageal varices? So the portal vein you have to recognize is your left gastric vein. Your systemic vein are your esophageal veins. So if we look at that on a pictorial representation, we have our left gastric vein, which here's our left gastric vein, this whole thing here. And if you have any backup of fluid, so if you have liver cirrhosis, you're going to get a backup of portal fluid. And again, if this doesn't make sense, we talk about this in the liver section, so I don't want you to be alarmed. What's going to happen though is that this connects with the esophageal veins up here. And so that backflow can actually connect up here and cause some bleeding. And that's how you get esophageal varices. What if you find somebody with painful hematemesis and somebody who either has bulimia nervosa or somebody who's been binge drinking? And if you do an endoscopy, you'll find a longitudinal mucosal tear. So now we're talking about Mallory-Weiss syndrome. And here's Mallory-Weiss. If we have our lumen, it'll just be a mucosal tear in a longitudinal mucosal tear, and it won't be a full transmural tear. And which blood vessel is most often affected in Mallory-Weiss syndrome? That's going to be your left gastric artery. And here we go. From our esophagus lecture, you'll see bleeding from that left gastric and painful hematemesis. And here's a slide that I've just mentioned that Mallory-Weiss is associated with this gastric artery bleed. And as well as this is also where this is the same artery. So Mallory-Weiss would probably be up here, as your left gastric comes up, it'll probably be a tear in this area because we're still talking about your esophagus. Here I'm talking about gastric ulcers will also involve the same left gastric artery. Let's contrast that with this next one. What if you have painful hematemesis in somebody with bulimia or after binge drinking? But this time, the physical exam will show Hammond's crunch. You might find pneumomediastinum on X-ray or crepitus on physical exam. You'll have esophageal perforation with this. So this is more dangerous. This is Boerhaave syndrome. And instead of Mallory-Weiss, where you just have the mucosal tear, this time you're going to have a transmural tear. And what that can cause is air to enter into the mediastinum. And so that's why you get some of those, the Hammond's crunch, the pneumomediastinum, that's because of the air entering. And there you go, painful hematemesis you're going to see. And how should you evaluate? This is more of a step 2 thing, but I want to include it. So how should you evaluate the esophagus in Boerhaave? The answer they love is this, they'll either say gastrographin esophagram or they'll say water-soluble contrast esophagram. These are the same things. They don't want you to do barium right away, because if you put barium in right away and it gets into your mediastinum, it can actually cause a life-threatening mediastinitis. They also don't want you to initially do an EGD if you suspect Boerhaave syndrome, because you might actually worsen the perforation. So that's something to keep in mind. And here, I mentioned this in the esophagus lecture as well. So you can take a look at that if you'd like. How about stomach conditions that cause GI bleed? So what's a GI bleed that's caused because of imbalances between gastric acid and mucosal defenses? There's an association with NSAID use, alcohol, burns, increased intracranial pressure, shock, and chemotherapy. That we're talking about acute gastritis. And acute gastritis, I tried to keep it simple when we talked about it in the stomach lecture. It's just basically where you have an imbalance to where you have too much acid and not enough defenses. And in that section, I go over why all 6 of these can cause acute gastritis, and that can cause bleeding. What if you have GI bleeding and painful hematemesis? This is the most common cause of upper GI bleeding in a non-cirrhotic patient. This is describing peptic ulcer disease. And so kind of breaking down peptic ulcer disease, what if you have GI bleeding in somebody who has long-term NSAID use or H. pylori infection? It's commonly located on the lesser curvature of the stomach. So this is a gastric ulcer. And the artery involved in a bleeding gastric ulcer, it's the same one we just talked about with Mallory-Weiss syndrome. That's the left gastric artery. And how about the artery involved in a bleeding posterior duodenal ulcer? That's going to be your gastroduodenal artery. And here's our slide we had talking about peptic ulcer disease. I just wanted to mention when we're talking about bleeding specifically, your lesser curvature ulcers tend to bleed from your left gastric, whereas your posterior duodenal ulcers tend to bleed from your GDA, your gastroduodenal artery. And here's your gastric ulcer. So if you had a lesser curvature gastric ulcer, you're going to get bleeding here. If you have a posterior duodenal ulcer, you're going to be bleeding from here. And what if you had GI bleeding, weight loss, iron deficiency, anemia, and anorexia in somebody who has chronic autoimmune gastritis? So that's describing somebody who may have gastric adenocarcinoma. And again, in our gastric adenocarcinoma lecture, I mentioned anemia as a cause, and that's likely due to acute, like occult blood loss causing iron deficiency anemia. I put gastric adenocarcinoma, but any of the cancers. So I could have included squamous cell carcinoma of the esophagus. I could have included esophageal adenocarcinoma as well. So any of the cancers honestly can cause some sort of GI bleeding. Don't think it's unique to gastric adenocarcinoma. And here's some of the risk factors. I just mentioned this person had chronic autoimmune gastritis, so they'd be at risk, but any of these risk factors can be a cause. And keep in mind, there's a totally different pathway that doesn't even require these risk factors. As long as you have this mutation, it can cause it. So, okay, how about for the intestine? So let's talk about that. So what if you have chronic diarrhea plus or minus bloody stools and iron deficiency anemia in a young woman? You'll see it tissue transglutaminase positive, and you usually treat it with dietary modification. So we're describing celiac disease. This is the mechanism that I talked about in the small intestine lecture, where basically your T cells will release cytokines and damage your duodenal epithelium. So you can get iron deficiency anemia in two different ways. One way is that you're just damaging your duodenal enterocytes, and your duodenum is very important for iron absorption. So it makes sense that if you have less enterocytes, you're going to have less iron absorption. All of this damage can also directly cause GI bleeding, which would also cause iron deficiency anemia. So two different ways you can get it. And there's the iron deficiency anemia we're talking about. What's the most common cause of GI bleeding in a young male? And it's related to ectopic tissue growth. Now we're talking about Meckel's diverticulum. And so if we go to here, we can notice that painless GI bleeding, especially hematochezia, because it's a lower GI bleed, is the more common. It's more common than melena. And here's our pathogenesis that I showed you in the small intestine lecture. Normally, you have your vitelline duct connecting to your yolk sac to give you some nutrients until your placenta develops. But once you have your developed placenta, you're not going to need any of your yolk sac or your duct anymore. So it's supposed to involute to this region. In Meckel's, you still have a residual vitelline duct. That's the whole problem. And this duct can contain stem cells that can produce things like gastric mucosa. So if you're producing hydrogen ions in your colon, that can easily cause a GI bleed because you have nothing to neutralize it. So that's why you get GI bleeding in Meckel's. What if you get colicky abdominal pain that improves when you the legs are drawn inwards, and you'll see this as a current jelly stools in a child. So this is describing intussusception. And again, from our small intestine lecture, I just want to mention that you can get current jelly stools from this disease. This is what current jelly looks like. So what's happening here is that as this part of the bowel is going through this part, what's going to happen is that the cells on this are going to get ischemic and they're going to die off. And when they die off and they slough off into the stool, you're going to get a lot of blood and mucus, and that's what causes that current jelly stool. What if you have bloody stools, fevers, transmural inflammation? You can also get strictures, creeping fat, and it's anti-Saccharomyces cerevisiae antibody positive. Now we're describing Crohn's disease. And again, this is from our colon lecture. I just want to mention that both Crohn's and UC can cause diarrhea. It can be bloody diarrhea. It can be non-bloody. So you have to keep both of them. They do like it. On tests, they favor the bloody diarrhea subtype more than the non-bloody for sure, but keep both of them in mind. And again, here's from our colon lecture. Just keep in mind all these differences between Crohn's and UC before test day. And here we go. We have bloody stools, fever, continuous lesions. You have your lead pipe sign. So now we're referring to ulcerative colitis. Again, this is the exact same slide I just showed. Doesn't matter if it's Crohn's or UC, they can all present with these similar symptoms. So that's why knowing the differences, such as that lead pipe sign, crypt abscesses, all these different complications, knowing these are especially important in distinguishing Crohn's and UC. So let's keep going. So what's the most common cause of GI bleeding, especially profuse GI bleeding in the elderly? The risk factors will include age, constipation, and a low fiber diet. That's describing diverticulosis. And so if we go to our diverticulosis slide, we mentioned this painless GI bleeding before. And what's happening is that there's a blind pouch that protrudes, and this blind pouch can bleed and cause the bleeding that we're discussing. What's the second most common cause of GI bleeding in the elderly? And it's associated with vascular malformations. So this is talking about angiodysplasia. And again, this is from the colon section. You can see GI bleeding here. What happens here is that you have your you basically have your arterioles, and then you have your venule to form your capillary, and then you have a bunch of capillaries attached here. So you have your arteriole, venule, and then these are all capillaries. And what happens here is that you actually get dilation of this capillary bed here, especially on the venous side, and that can cause a back pressure in the capillary, which you wouldn't want. These capillaries are not meant to withstand any sort of high pressure, so they can each rupture and start causing hematochezia. The third most common cause of GI bleeding in the elderly, this will definitely present with other symptoms like weight loss, iron deficiency anemia. Now we're talking about colon cancer. So if we go to our colon cancer slide from before, you'll notice there's GI bleeding as a symptom. And that's why anybody who has iron deficiency anemia in the elderly, they always want you to order a colonoscopy to make sure that it's not colon cancer. And now they also like to test the laterality, because right and left-sided colon cancer tend to present a little differently. So which sided colon cancer is more likely to bleed? That's going to be your right-sided tumors. Here's our chart from our colon section as well. And you can see that the right-sided is known for bleeding. And my mnemonic for this is that anything that has 5 letters in it is going to be a right-sided thing. So right has 5 letters, bleed, micro for your microsatellite instability, and Lynch for Lynch syndrome. So all those are right-sided. And intuitively, this makes some sense because we talked about in our colon, where our right side of our colon is a lot larger, and it's got a lot more of a fluid material still, because not all the fluid has been absorbed. And so because of that, it's harder to have an obstruction. That's why you're going to see obstruction later on in the GI tract, when the lumen's a little smaller and the stool is a lot more well-formed. What are benign colonic protrusions into your lumen called that may cause GI bleeding? So those are colon polyps. I drew a couple polyps here. This is like a sessile polyp and a few pedunculated polyps. And just know that large polyps can cause bleeding or obstructive symptoms. How about bloody stools and abdominal pain that might occur after somebody's had a shock-like episode? It usually affects the watershed areas, like the splenic flexure and the rectosigmoid junction. So we're talking here about ischemic colitis, where again, you have bloody stools. Just remember, they're always going to give you some sort of recent hypotensive episode if they want you to pick this. And they really like you to know the watershed regions that we talked about earlier in this lecture. How about somebody who has severe abdominal pain and bloody stools in somebody who has every vascular risk factor under the sun: hypertension, hyperlipidemia, type 2 diabetes, coronary artery disease, they've had an MI before, they've had a stroke before. When you do their physical exam, it's going to be normal, which is unusual given how much pain they're in. So we're talking about acute mesenteric ischemia here. And again, you're going to see that those current jelly stools, we saw that in intussusception. You're going to see it here as well. And it looks like that. And so what's happening here is that in acute mesenteric ischemia, what happens is that you usually have some sort of embolism. So you have a clot that breaks off, goes all the way down. It skips your celiac trunk because of how the angle of the celiac trunk is compared to your aorta. It's hard for that clot to get lodged in there. It usually gets stuck in your SMA. And as some of your bowel starts to die off, it'll slough off some of that material into your GI lumen, and that's why you get that current jelly stool. Okay, let's keep going. We just have a few more slides left in this lecture. So what happens if you noticed blood on your toilet paper after you wipe? It's painless, and it usually happens in young adults with constipation. So we're describing internal hemorrhoids here. And going back to this same lecture, just a few slides ago, we noticed that internal hemorrhoids will bleed and they will not be painful. They won't be painful because they have visceral innervation. And we contrasted that earlier with external hemorrhoids, which are painful because they have somatic innervation, but they tend not to bleed. How about if you have somebody who has pain during defecation and you notice blood on the toilet paper when you wipe? It's caused by a painful tear in the anal mucosa. And so we're talking about anal fissures. And again, this is just from our section just a few slides above, where we have blood when wiping. Again, another one we talked about earlier today. It's GI bleeding due to rectal vein anastomoses in somebody who has underlying portal hypertension. Those are your anorectal varices. And what happens there is you have a buildup. It goes into your systemic veins, your middle and inferior rectal veins. And because they're not equipped to handle those pressures, it can bleed. Which medications are commonly associated with GI bleeding? There's just a couple. So NSAIDs we've talked about before in the setting of gastritis, especially. And anticoagulants are always going to increase your risk of bleed. Steroids can also, that's something I haven't mentioned before, but steroids are a known risk factor for gastritis. So people who are on high dose steroids often receive a PPI to try to protect them and decrease the risk of developing gastritis and a subsequent bleed with it. And just a couple random conditions now. So what if you find intracranial and GI bleeding in a newborn who did not obtain adequate postnatal care? So this is hemorrhagic disease of the newborn, which we've discussed. And what happens here is that most people who, when they're born, they are given a vitamin K injection because our gut flora cannot synthesize vitamin K efficiently in the early weeks of life. And if you have no vitamin K, you're at increased risk of bleeding because you aren't able to synthesize a lot of your clotting factors that you need. And what's the life-threatening complication typified by profuse bleeding and clotting symptoms? We haven't discussed this yet in this series. I'm going to talk about it as one of the complications of pancreatitis. You can also see it as a complication of trauma, sepsis, OB-GYN. A lot of OB-GYN syndromes have this as a complication. This is called disseminated intravascular coagulation, or DIC. And again, when we talk about it in the pancreas lecture, I just mentioned that you can get significant bleeding as well as other symptoms like clotting symptoms. I just included one slide on a couple of step 2, level 2 specific pathologies. Even on step 2, these are pretty low yield, but I thought I would include it just to try to be as comprehensive as I could for you all. So this is a rare condition, GI bleeding in the stomach. It's caused by friable ectatic vessels. It's related to portal hypertension, and they will give you the snakeskin appearance on endoscopy. This is called portal hypertensive gastropathy, or PHG. And so you can see this snakeskin appearance of the stomach on endoscopy. Instead of a snakeskin appearance, this is called watermelon stomach, and this is caused by dilated pyloric antrum blood vessels, and it's associated with cirrhosis and also associated with certain autoimmune conditions like scleroderma. So this is called gastric antral vascular ectasia, and you can see the watermelon, it kind of looks like watermelon stripes here inside the pyloric antrum lining. What if you found this is a disease that is typified by a tortuous arteriole in your stomach submucosa that intermittently bleeds? It can be diagnosed on endoscopy, but it's often missed because it'll bleed and then it can heal up before you even do the EGD, so it's very hard to catch sometimes. This is called Dieulafoy's lesion. What's it called when you have a hiatal hernia? So that's a hernia where your stomach is going through your stomach is basically getting pushed superior, and a portion of your stomach is above your diaphragm now. So a hiatal hernia that's causing damage to your gastric lining due to friction between your stomach and diaphragm. This is called a Cameron lesion or a Cameron ulcer. So if I go here, what's happening in these pictures here, this is the same person. Their whole stomach, the diaphragm in this case would be like right here. And in this case, the diaphragm's like right here. What's happening is that the diaphragm is compressing that region of the stomach. The stomach's not used to getting compressed like that. So it can actually cause some damage to these regions here. And these Cameron lesions or Cameron ulcers can bleed. And there's a special syndrome typified by GI bleeding from angiodysplasia in conjunction with aortic stenosis. And this is called Hades syndrome. And they think what happens here is that you have aortic stenosis and it damages von Willebrand factor. And if you have decreased von Willebrand factor, you can't adequately form your platelet plugs, and so then you might have GI bleeding. That's the theory I learned from whoever taught me that. Said that the theory is still kind of up in the air, so you'd have to check on that. It's pretty low yield regardless, but I just wanted to mention that. And the last thing, what happens if you see somebody with extremely profuse GI bleeding following a recent aortic procedure, like an abdominal aortic aneurysm repair? So that is an aortoenteric fistula, which, as you can probably guess, is life-threatening if your aorta now has a connection to your GI tract directly. And you'll always have that in the setting of some sort of recent aortic procedure. And that'll do it for GI bleeding, and I believe that does it for our rectum lecture. So I know this lecture specifically was a little bit different than most of our other ones. I tried to make it as useful as possible because a lot of step 1 resources don't go into that great of detail about acute and chronic diarrhea and GI bleeding. So I hope this section at least helped you to form a framework and help you with a differential when you see questions of that nature. So next time I'm going to see you will be for the pancreas lecture for our eighth part of our 10-part series. So thank you all for joining.